Thank you, Mary, for such nice introduction. First of all, I would like to express my deepest thanks and gratitude to such an honorable invitation. We are gonna talk about neonatal lung protection, the golden hour. I have nothing to declare. Our main objective today is to understand the perinatal adaptation and the physiology of breathing, the most important lung protective strategies in the delivery room. We all know that fetal lung development passing through embryonic, then pseudoglandular, canalicular, saccular, and alveolar stage. Actually, this process continue to growth up to 7 years of age. Doesn't end by birth. No, lung development continue to occur till 7 years of age. Intrauterine, as we see in this video, the fetal lungs are secretory organs. You see this baby have a breathing-like movement. This movement serves to help lung development. The alveoli secreting about 200 to 300 milliliter per day. So the fetal airways are not collapsed. They are filled with fluid. And the presence of fetal lung fluid is essential for the fetal lung development. Here, the pressure volume loop of an air-filled lung, and on the right side, this is the pressure volume loop of a fluid-filled airways. This is the normal pressure volume loop of the alveoli filled with air. With increasing the pressure, there will be increase in the intra-alveolar volume. Why? During the first breath in the delivery room, the alveoli are filled with fluid. So the infant needs to exert a huge surface tension to clear the airways from this fluid, reaching up to 40 centimeter water, and infilter may reach to 70 and 80 centimeter water pressure needed to inflate and clear the airways from the fluid. So for successful transition, we need to rapidly aerating the lung, clearing the fluid from the airways, maintaining a functional residual capacity, and this is associated with increase in the pulmonary blood flow. Our physiological goal of ventilation is to achieve and maintain gas exchange, restoring adequate functional residual capacity, reducing the work of breathing, and minimizing ventilation associated or ventilation-induced lung injury, which a combination of process, barotrauma, volutrauma, atelectotrauma, and biotrauma. The vast majority of lung injury actually, or unfortunately, is man-made. In order to avoid that, we have to apply this lung protective strategy from the first minute. It is a golden minute, not golden hour, it is a golden minute. We all follow the neonatal resuscitation algorithm, and there is an increasing evidence denoting that even brief, large tidal volume positive pressure ventilation can cause permanent damage. So there is a debate to observe and gentle management of resuscitation in the face of interventional invasive management. As few as 6 large tidal volumes are enough to cause widespread histologic lung injury and compromising the therapeutic effect of the subsequent surfactant replacement. That's why we are concerned with the lung protective strategies from the first breath. Again, it is the golden minute, so we have to be prepared before birth with the 4 routine pre-birth questions, arrangement for delayed cord clamping and skin-to-skin, team briefing, clarifying the roles and responsibilities of each one of us, and delegate tasks. Maintaining normothermia is a very important step in lung protection, because hypothermia increasing risk of respiratory distress syndrome, hypoglycemia, IVH, late onset sepsis, increasing the mortality. So we have to maintain the room temperature at 23 to 25. In preterm infant, we can use a thermal mattress, a plastic wrap or plastic bag, or even a hoodie to maintain the normothermia of our baby. If you are gonna use oxygen, we will start with a free flow oxygen at 30%. Preparatory check for your equipment, adjusting the FiO2, the flow liter, about 10 liters per minute, and know according to the gestation age of your baby, you are gonna adjust the FiO2. We are saving the 100% oxygen only to be used during chest compression if needed. Evidence said that meta-analysis of 10 randomized control trial comparing low versus high oxygen used during the resuscitation, and they reported no significant difference between both high and low initial FiO2. So there is no need to give a high oxygen. It is not superior to the FiO2 of 21 to 30% in reducing the risk for bronchopulmonary dysplasia. The second lung protective strategy is to use early Cpap in neonate born less than 32 weeks. Instead of routine intubation and surfactant administration that we used to do, what we call ensure technique, now we apply the early Cpap. And why we use this technique or this strategy? Our aim is to avoid the injury zone, avoid the zone of atelectasis and the zone of overdistension. We need to work on the safe window. This is the alveoli atelectatic zone, and this is the safe window, and this is over distension in the alveoli. These are our physiological goal of ventilation, to work in this safe window. Early Cpap facilitated lung recruitment, preventing parotrauma and volutrauma, so protecting the lung from injury. This is the BP loop during the first breath. As we have said before, during intrauterine life, the lung here, this is a phase contrast imaging. The air appears white, bright, and the fluid or a collapsed atelectatic alveoli appears like here. So, before the first breath, in order to clear the airways, we need as much as minus 20 to 30 centimeter water to overcome the critical opening pressure. At point A, there is 10 centimeter and 20 centimeters starting. Here, the alveoli are totally collapsed and filled with fluid, starting aeration. And this is what we call a critical opening pressure. And here, uniform distribution of ventilation in the upper and lower quadrants. This is during the first breath. Again, why do we need PEEP? If we don't use PEEP, I mean zero PEEP, this is the lungs at the end of expiration, showing low functional residual capacity, no air in the airways, the lung totally collapsed, filled or atelectatic. And at the end of inspiration, there is only aeration of the proximal airway with 0 PEEP. While if we apply the higher PEEP, we will recruit the alveoli. This is at the end of inspiration, there is uniform aeration of the upper and lower lung quadrants bilaterally. And at the end of expiration, the functional residual capacity is much improved than 0 PEEP. This is again another video strategy starting okay. This doesn't work. I don't know why. Just a moment. This video it was gonna we are gonna skip it. It was gonna show the same picture at 0 PEEP, at 5 PEEP, at 10 PEEP in an experiment done by Siri et al. 2014. Here is the lung volumes at the end of inspiration using 0 PEEP, and here using 5 PEEP. Here the functional residual capacity with 0 PEEP and the functional residual capacity with 5 PEEP at different points. These are preterm PUPs. So in a Cochrane meta-analysis, when we compare the Cpap versus mechanical ventilation, we found that early or primary Cpap reduced the risk for bronchopulmonary dysplasia and reduced mortality. Our baby is still not breathing well or apneic and need to give him a positive pressure ventilation. Again, wait. Do not rush to intubation, because the only consensus about mechanical ventilation is that avoidance of mechanical ventilation is the best way to avoid lung injury. So not to intubate. So then how come I'm gonna give him positive pressure ventilation? Either using free flow, either self-inflating bag or T-piece resuscitator with a mask. Again, keeping the targeted pre-ductal oxygen within limit, saving the 100% oxygen to chest compression. What do we mean by sustained lung inflation? As we have discussed and seen before, that the liquid have higher viscosity, requiring higher time constant to get rid of the liquid from the airways. So prolonged or sustained inflation applied after birth found to be more effective than short inflations in clearing the lung fluids. This is one way of lung protective strategies, applying a pressure controlled from 20 to 50 centimeter water, sustained for 10 to 15 seconds, followed by delivery of 5 centimeter water using a neonatal mask and a T-piece resuscitator. Comparing this sustained lung inflation versus manual inflation with self-inflating bag and mask, Cpap et al. Showed that the need for intubation, the days on mechanical ventilation, the days on Cpap, risk of air leaks, bronchopulmonary dysplasias, all these were significantly lower in sustained lung inflation group. Also, meta-analysis compared 4 randomized control trial comparing sustained lung inflation versus Cpap and versus IPPV showed that none of them was superior to reduce the risk of bronchopulmonary dysplasia nor death.
A recent study published in JAMA Pediatrics 2020, it's a systematic review and meta-analysis of 9 studies recruiting 1,406 infants, comparing sustained lung inflation versus the standard resuscitation of a preterm. The outcome measured death before hospital discharge. They found no difference in the risk of mortality before discharge, no evidence of efficacy for sustained inflation to prevent the secondary outcomes. Such finding supports do not use routine sustained lung inflation for preterm infants after birth, which also stated clearly in the European consensus not to use sustained lung inflation. Instead, we use a Cpap of 6 in a spontaneously breathing baby.
How and when we are gonna administer surfactant. There has been a long discussion, prophylactic versus rescue strategies, and many randomized controlled trials compared ensure technique means intubation, surfactant insertion, then extubation. They compared ensure versus nasal Cpap, and they found neither of them was superior in reducing the mortality nor bronchopulmonary dysplasia. So, wait, and still nasal Cpap is as effective as ensure technique. Early versus late administration of surfactant, Cochrane meta-analysis showed that early surfactant decreased the risk of bronchopulmonary dysplasia, the mortality, compared with late surfactant. Since the Cpap became the standard treatment of infants with respiratory problem, so many invasive surfactant therapy, what we call MIST, applying surfactant to a spontaneously breathing baby via several techniques, whether aerolized, and this is the future discussion, laryngeal mask airway, pharyngeal instillation, or thin catheter, what we call it, less invasive surfactant administration, or LISA. You can use umbilical artery catheter, vascular access catheter, nasojejunal tube, LISA catheter. Use a thin catheter to apply, to give surfactant while maintaining the function of the glottis and continue spontaneous breathing, avoiding sedation and analgesia, avoiding regular intubation, and positive pressure ventilation. Meta-analysis compared LISA versus ensure, LISA versus Cpap, LISA versus surfactant and invasive mechanical ventilation. All these comparisons show that LISA have decreased the need for invasive mechanical ventilation, decreased the risk of bronchopulmonary dysplasia and mortality. During LISA administration, we use caffeine to stimulate the respiratory center. CAP trial was initiated in 2006, and caffeine administered have shown to be effective in reducing the positive pressure ventilation duration and less bronchopulmonary dysplasia in those groups than placebo infant. It is now the standard of care in respiratory management of preterm infants. Another new therapy is intratracheal budesonide administered with surfactant, with a significant reduction in the outcome of mortality or bronchopulmonary dysplasia. Undergoing research about high-flow nasal cannula. High-flow nasal cannula improves oxygenation, improves ventilation, and decreasing CO2 reprieve from the anatomical dead space. However, the preliminary studies showed that it's still inferior to Cpap in terms of failure. High-flow nasal cannula in the delivery room. We are discussing in the delivery room. Future show future evidence experiencing artificial womb used successfully to grow premature lamb for 2 times till now. Again, we are looking for the future. If you had to intubate your patient, please extubate early as you can. And listen to your patient. Let the kid make his or her own ventilator changes. Thank you.
So, our take-home message for state-of-the-art lung protective strategies in the delivery room, summarized in the European Consensus Guidelines on Management of Respiratory Distress Syndrome 2019 update. First, delayed cord clamping of the umbilical cord for at least 60 seconds. In a spontaneously breathing baby, stabilize with Cpap of at least 6 cm water via mask or nasal branch. Do not use sustained lung inflation. There is no long-term benefit. Instead, for persistently apneic and or bradycardic infant, use gentle, non-invasive, positive pressure ventilation with a PIP of 20 to 25 and PEEP of 6. Oxygen used only through controlled blender with the initial FiO2 of 30% for babies less than 28 weeks and 21 to 30% for those between 28 to 31 and less than and 21% for those 32 weekers and above. 4. If intubation is indicated in a baby not responding to non-invasive ventilation, so intubate the baby at ease, and those who require intubation, it is essential to give them surfactant if not given earlier via LISA or MIST.